Moving on to the next topic, we'd like to call upon the chairpersons, Dr. Sridhar K., who's the consultant physician and diabetologist at DIA, Specialty Diabetes and Thyroid Center, also the treasurer for the RSSDI Karnataka chapter. Also would like to invite Dr. P.S. Badri, who's the consultant physician at Gauri Bidnoor. We welcome you on stage, doctors.
Good evening, everyone. I thank Dr. L. Srinivas Murthy and ILET Academy for giving me an opportunity to chair the session. May I invite Dr. Sanjay Agarwal, physician and head of Department of Internal Medicine at Ruby Hall Clinic, Jahangir Hospital and Apollo Group of Hospitals, and past secretary for the RSSDA. Over to you, Dr. Sanjay Agarwal.
Thank you very much, Sridhar. Can I have my slides, please? I think that's a very old introduction. Okay, thank you so much. I think we've had some great lectures. Last 3 or 4 lectures have been rather very enlightening. And I think it kind of adds up sequentially, one leading to the other. And I'm kind of taking the thought further from what Dr. N.K. Singh projected in terms of muscle health. And why do we really now talk a lot about exercise? It's not that we didn't talk about exercise before. And if you look at all our algorithms for treatment, we always say lifestyle modification, and then comes the pharmacotherapy. But when we talk about lifestyle, we say diet and exercise rather very loosely. And we leave the patients with the thought that what kind of exercise or diet a person should follow. It's become now more in focus because now we are realizing the importance of muscle health. And because we are realizing the importance of muscle health, we are forced to say that how can we preserve muscle and make it more sort of, metabolically healthy. And that's the reason why I think the conversations of exercise becomes extremely important. You're not going to be privileged to have an exercise physiologist in your clinics all the time. It's important that when you speak to the patient, you should have a plan for the patient as to how he should exercise. And in the next 20 minutes, I just want to lay out a skeleton for you so that in your clinical practice, you're able to at least formulate some form of conversation with the patient as to how he can do his routine exercise on a day-to-day basis. Now, remember that exercise is a glucose-lowering therapy. It's not an optional adjunct. And if you look at studies, it causes about 0.5 to 0.7% reduction in the A1C. If you do a 2 hours to 72 hours, when you map them out, when you do a consistent exercise, it improves the insulin sensitivity after even a single exercise session. And I'm going to talk to you a little while later that if you break sitting every 3 minutes for every 30 minutes, you find that it lowers the postprandial blood glucose. And a combination of strength training with aerobic activity is rather beneficial than doing each one of them alone. So you should prescribe it like a medicine. It should not be like an optional that the patients can follow. You have to make it insistent that just as you take medications, exercise is not really an option for you. Now, how does really exercise change physiologically? If you look at the skeletal muscle, it improves the glucose uptake, and this is an insulin-independent disposal that tends to happen. It also improves the mitochondrial function. At the liver, and the insulin level, it increases the insulin sensitivity, it decreases the hepatic glucose output, and it decreases the postprandial glycemic load. At the fat level, the adiposity, it decreases the visceral fat, which favors the body composition shift towards a weight-neutral benefit, which still occurs. At the cardiorespiratory, it increases the Vmax, VO2 max, and it improves the walking efficiency. And in the functional level, it improves the strength and balance, Particularly, this is more important when you look at the elderly population, where they have gait issues, they have frailty, they tend to be very unsteady, and they may lose balances, they may have falls and fractures. So it's very important that you prescribe for all elderly people a balancing exercises. We don't really seldom do that, and very often patients come and tell us that I'm not able to walk, I tend to be unsteady, I've had falls, and we don't really pay too much attention on the balance of a patient when he walks. Now, this is a very important small tips when it comes to physical activity, which may drastically improve glycemic control. And this can be done on our day-to-day activities. The 3/30 rule, where you perform 3 minutes of light physical activity after every 30 minutes of sedentary behavior. You interrupt prolonged sitting directly, and it enhances the insulin sensitivity and blunts the postprandial hyperglycemia. And your total daily recreation screen time must be aggressively capped to under 2 hours. And I think this would also be an extension to what Dr. Arvind Gupta mentioned about the amount of screen time that you have exposure to. And he showed that very beautifully that, you know, when you have a lot of screen time, there's a lot of blue light emission that tends to happen and does disturb your sleep-wake cycle in that sense. Now, we have various types of physical activity. Aerobic activity, which improves the body composition and cardiorespiratory fitness. Muscle strengthening activity, which improves the muscle fitness, such as muscular strength and endurance. You've got the stretching activity, which improves the flexibility, such as range of motion. And you've got neuromuscular activity, which improves the neuromuscular fitness, such as balance, agility, and proprioception. So when you sort of advise a patient, you know, very often patients come and tell us that I do 10,000 steps or 5,000 steps every day of walking. I say that's useless. I mean, you're not really doing enough what would be required for your body. You have to combine aerobic activity with the muscle strengthening activity. You need to have flexibility of joint motions, and you need to do a lot of stretching activity. So it has to be a combination of activities that you tend to do. And when people tell you that I just walk so much steps, I think you need to emphasize to them that that's not really good enough for you. So if you have to write out a clinical prescription algorithm, you need to assess the baseline. So is this patient healthy or is he fragile? And what kind of a multi-component exercise fitness regime would you like to give the patient? Number two, you have to screen for complications because the exercise prescription would depend on the cardiorespiratory fitness, his neurological fitness that he's got. How's his muscle strength? Does he have comorbidities, macrovascular complications, according to which you need to design the exercise program for an individual. You need to see what kind of a modality you need to give a particular patient. And when I come to the case discussions, I'll point out to you how this is very important. And you need to shield the patient against important things like hypoglycemia, falls. These are very important that when you design the exercise regime, you need to make sure that you're thinking. And you need to assess the patient for autonomic neuropathy because sudden changes in postures can suddenly cause giddiness and, you know, blackouts that may tend to happen. So you need to be very careful that you pre-screen the patient for all these things. Now, when you sort of design a treatment, exercise treatment, you follow the FIT principle. F stands for frequency, I stands for intensity, T stands for time, and the second T stands for type. And all these four components really need to be met. So frequency, how often do you want the exercise to be conducted for an individual? What kind of an intensity program that you need to do? So is it light exercises, moderate exercises, vigorous exercises that you need to do, and how often you need to repeat them? Time in a particular day or in the number of hours in a particular week that you need to determine, and timing, type of training that you need to do. So whether you like to do only aerobic or you want to combine aerobic with resistance training, all this is very important to determine. And ADA this year added two more. That's volume and progression. So volume is the total amount of week minutes that you do, the steps, the accumulated activity. And the progression is you start slow and you build up an exercise. So you can't do suddenly a lot of exercise on day one. You need to start with a lower level and then graded exercise you need to do, so build it up. So they have now said FIT, VP, that's volume and progression, that you really need to talk to the patient about. Now, is the sequence important when it comes to patients with diabetes? So should you ask the patient to do an aerobic exercise first and then follow it up with resistance exercise? Or should you ask resistance exercise to be done first, followed by an aerobic exercise? And if you look at the glycemic maintenance in the blood, you find that if you have somebody who does aerobic first, followed by resistance, their glycemic levels tend to go down, right? And if you have resistance followed by an aerobic, you find that the glycemic level tends to be very steady. Now, this is important when you anticipate that somebody is likely to develop hypoglycemia. You need to be very careful as to what kind of exercise. Majority of us would tend to ask the patient to do resistance first, followed by an aerobic, and that's more practical to be done. So you do 45 minutes of heavy resistance exercise with 8 to 10 repetition maximum that you need to do, so repetitive maximum movements that you ask the patient to do, and then perform about prior to 45 minutes with aerobic exercise. The effect is, of course, it drastically attenuates the expected drop in blood glucose during the subsequent aerobic phase. And why is the lifting of heavy weights triggers a robust growth hormone and lactate response. Now, these are the different aerobic exercises that you can do. And I'm just following the FIT principle. So you may have a low, moderate, or high. And this is what it really impacts on the right side. Because of want of time, I'm not really going to get into it. But it impacts the cognitive functions. It also helps in the executive function, memory, progression of age. It reduces the age-related cognitive decline. And it increases the attention span. So you have a lot of benefits that tend to happen with aerobic exercise, and depending on what low, moderate, or high you would like to advise the patient. What about resistance exercise? And you find that they've just demonstrated the resistance exercise where you've got weights that you're using out there or stretches that you're doing. And again, the FIT principle that you follow, where you can do 2 to 3 sessions per week for 2 to 12 months or longer. And the I stands for 40 to 80% of one resistance maximum. That means one time how much maximum weight a person can pick up. Then T is 40 to 60 minutes per session. And each session should include at least 7 exercises with 2 sets and 10 repetitions per exercise. And then weightlifting, the type is weightlifting, body weight training exercises with TheraBands and resistant tubing. So you can do all of this, but look at the benefits that this tends to cause, again, impact on the cognitive functions, and this is the pathways by which it happens. Then you've got, of course, if you do combined strength and aerobic exercise, where I've just listed out the exercise right at the top up there, and you follow the FIT principle again out here, you find that it has impact on the cognitive functions, but also on the mechanical functions and the physiological functions that the patient tends to have. So in short, I think you've got aerobic, resistance training, and a combination of both. And most of us would tend to ask the patient to do a combination of aerobic and resistance training. Now, is the timing of physical activity have an impact on the glucose lowering effect? And this paper has been published as an extension of the Look Ahead trial group, where they looked at that, okay, they had 2 groups. One was, of course, diabetes support and education, the control group, and the second was the intensive lifestyle intervention. And they said that, okay, look at the timing of the exercise and what it does to the glycemic level. So they looked at glycemic measures and the timing. So mixed is, of course, any time of the day. Then you did it at morning, midday, afternoon, and in the evening. And you look at the graphs over here. The conclusion was that the afternoon group had the greatest reduction in the A1C, 30 to 50% larger reduction than other groups in year 1. And this was probably sustained along the time, all the way up to 4 years. But what about timing of moderate to vigorous physical activity in terms of mortality, cardiovascular disease, and microvascular disease in adults with obesity? So this is equally important, that you find that people tend to have comorbidities, and is it safe for them to do it? So what is the correct timing for an individual to do the exercise? And this was from the UCO Biobank study, and they looked at patients with obesity. there were patients, almost about 3,000 patients who had concurrent diabetes too. And they said, okay, can you do morning, afternoon, or evening, moderate to vigorous physical activity? And the outcome studies were incidence of all-cause mortality, incidence of cardiovascular disease, incidence of microvascular disease, nephropathy, neuropathy, and retinopathy. And the conclusion was that the evening moderate to vigorous physical activity was consistently associated with the lowest risk of mortality, cardiovascular disease, and microvascular disease in adults with obesity. So evening exercise is good for you in terms of safety. Afternoon causes the maximum drop in terms of the blood glucose values. Now I'm just going to shift tracks and take up some case vigilantes so that we can really put all this perspective in terms of case studies, right? Now here's my first case where we've got newly diagnosed urban type 2 diabetes with central adiposity. And this is like a typical desk-bound Bengaluru professional that we've got, a 42-year-old man, software professional, prolonged sitting for more than 10 hours a day. A1C is 8.1, BMI is 29, waist is 104. His triglyceride rich, dyslipidemia, probably has associated mast cell and NAFL phenotypes. Patient is on metformin, no established ASCVD, no exercise habit, reports post-dinner lethargy and poor sleep. And the goal is, of course, in this patient is improve the glycemia, address the hepatometabolic risk, cardiorespiratory fitness, and the adherence. Now, mind you, A1C is 8.1, waist is 104, and the patient has got a sedentary job. What would you advise this patient? So this would perhaps be the prescription that I would give the patient in terms of the FIT principle, 5 to 6 active days per week with a written target of no more than 30 to 45 minutes of uninterrupted sitting during work hours. Intensity should be that moderate rate that you need to do 11 to 13. So it's basically rate of perceived exertion. That's RPE. That how much is he able to perceive the activity level that he's done, and there's a scoring to it. And he should be able to talk in phrases. The time should be, of course, start 25 to 30 minutes per day, brisk walking, plus 10 to 15 minutes of post-dinner walk on most days. And type is, of course, walking first, add 2 weekly resistance sessions using body weight plus resistance band for major muscle groups. And progression is, of course, as you want to tell the patient, increase the weekly volume by 10 to 15% until you have 200 to 250 minutes per week. So why this works is, of course, you have got a high adherence. Postprandial walking helps to blunt the meal-related glucose excursions. And the resistance works well to preserve the lean mass while improving the insulin sensitivity. And you need to monitor the step count or active minutes, waist circumference monthly, and monitor the A1C and weight and ALT at the follow-up if mast cell is suspected. Here's a case 2 that I have put out for you. He's a typically insulin-treated type 2 diabetes with fear of hypoglycemia. And this patient stopped walking because of lows, hypoglycemias. Now, she's a 56-year-old woman based out of Chennai, diabetes duration of 14 years. Patient is on basal bolus insulin plus metformin, A1C is 7.6%, has recurrent afternoon and occasional nocturnal hypoglycemias. And the patient avoids outdoor walking despite motivation because of previous sessions ended in shakiness. That's typical like a hypo symptoms the patient had. There was no active ASCVD, mild obesity, wants weight loss and confides and has confidence to restart the exercise. Again, A1C 7.6, patient is on insulin, has a fear of hypoglycemias. Now, what would be a prescription for such a patient? You start here. You schedule 1 to 2 hours of activity after breakfast or lunch rather than late evening initially. 10 to 20 minutes of moderate walking or seated cycles. Add 2 short resistance sessions per week. Chair squats, wall push-ups, and therabands that you can tell the patient. And you can use CGMs or SMBGs before or after initial sessions, carry 15 grams. So such patients, we always tell them, take some sort of a carbohydrate before the initiation of an exercise, and that perhaps may help to reduce the chances of getting a hypoglycemia. You again do medication adjustments or pre-planned bolus reduction before longer sessions when appropriate, review basal excessive nocturnal, and reinforce delayed hypoglycemia surveillance. And you make the behavioral changes of this patient. The third case that I've put out for you is a typical patient with distal symmetric peripheral neuropathy with plantar risk. And you've got patients who've got peripheral neuropathy and feet at risk. And the profile of such a patient would be a 60-year-old man, diabetes duration for 17 years, obesity, loss of protective sensation, has callus under metatarsal heads, has burning pain, wants to exercise, and this patient has a feet at rest. You obviously would like to preserve the feet and the joints and the muscle of this patient. So you do a recumbent and upright cycle, seated steppers, rowing, ergometry if feasible, chair aerobics or aquatic exercise. Do resistance training for 2 to 3 days per week with machines and bands. If walking is retained, use shorter bouts on even surfaces and footwear optimization. What you need to be very careful about is the pre and post sessions foot inspection, socks, shoes, and offloading reviews, and escalate if new blister, warm drainage, or focal pain occurs. So you need to be very careful in terms of advancing the exercise for such patients. Because of want of time, I'm going to skip the next two cases, but I just want to end up with a thought for you that we need to have a graded exercise for the patient. Can I take just 2 minutes more of time, please? Okay. So you need to decide every 2 weeks what is going to be the escalation of exercise that you're going to give. So week 0 to 2, 3 to 6, 7 to 12, and what will be your maintenance phase of exercise that you want to give the patient. What is important is when to de-intensify or hold the exercise in an individual when you consider that it is not safe. So address the glycemia, keep monitoring the A1C, CGMs, time and range, hypofrequencies. Look at the anthropometrics of the patient, hemodynamics, the foot, eye, and kidney status, and the function. But you hold exercise if the patient has got moderate or high ketones or marked hyperglycemia with illness, new chest pain, pre-syncope, disproportionate dyspnea, or arrhythmia symptoms, new foot lesions, warmth, drainage, or rapidly worsening neuropathic symptoms, new floaters, vitreous symptoms, or recent retinopathy intervention that the patient has got. This would be a practical sort of flow that you would look at in terms of diabetes practice. But what is important is this key take-home messages that I have for you, that exercise is not a generic advice. It is a diabetes therapy. Prescribe the fit VP not with vague lifestyle language. We often leave it very loose in our clinical practice that you need to exercise, but you never mention what exercise a person should really be following. Complications modify the mode and intensity ceiling, but not the value of exercise itself. So just because the patient has got complications, it doesn't take the patient off the exercise routine. You modify the exercise and give the patient. For Indian practice, the most effective plan is the one that fits the climate, household context, travel time, and safety. You pair exercise with glucose, foot, eye, and symptom monitoring when indicated, and progress the volume first and celebrate the adherence before athleticism. So you look at key takeaways is whole body adaptations, enhance the cardiometabolic health, personalized exercise prescriptions, and clinical impact. So thank you very much. This is me. I cycle every day for about 20 kilometers, and I think that's just one of my photographs out there. So thank you very much.
Hello.
So Bansi said that right. Thank you very much.
Hello. Thank you, Dr. Sanjay Agarwal. It was an excellent talk. Not only quantity of exercise is important, it's a quality and type, and the sequence of type is more important. You highlighted that. Thank you, sir.
Thank you very much.
Yeah, due to paucity of time, we are not taking
thank you so much,
questions.
speakers and chairperson. We would request you to move to the selfie area, which is outside the hall.